So RAINFALL study is based on the fact that ramucirumab, which is a monoclonal antibody against VEGF receptor 2, has become a standard of care in second-line treatment for patients with metastatic gastric and esophageal junction adenocarcinoma. That was based on two large phase 3 study with over 1,000 patients, which is called REGARD as well as RAINBOW. And with that, the combination of paclitaxel and ramucirumab is now a standard of care around the world. So with the success in the second-line setting, the first-line study, which is the current study RAINFALL, has been designed to see whether the additional ramucirumab to the standard of care chemotherapy, which is cisplatin and fluoropyrimidine with either 5-year capecitabine, would actually significantly improve survival compared to chemotherapy alone. So this is a placebo-controlled phase 3 randomized controlled trial, which is conducted in many different countries across different continents. Altogether, over 645 patients were randomized to either cisplatin plus 5-year capecitabine with placebo, or the same combination of chemotherapy with ramucirumab. In particular, in this study, in order to address a previous issue that gastric cancer patients do not seem to have a high enough ramucirumab level in the body, they actually adjusted the dose schedule of ramucirumab so that it was given on day 1, day 8 every 3 weeks. So this study was conducted, and the primary endpoint, which is using investigator-assessed progression-free survival, was in fact statistically significant with a p-value of 0.011 and a hazard ratio of 0.75. However, the overall survival, which of course is a very important endpoint in any phase 3 study, was not significantly different between the two arms. So ramucirumab, the addition of ramucirumab to chemotherapy, unfortunately did not translate into an overall survival benefit. So based on this, currently we would not recommend the addition of ramucirumab in patients who have untreated metastatic gastric cancer to be added to chemotherapy. From this large phase 3 study, we also have an opportunity to assess patient-reported outcome. So this is, as I said, is a large study, so we were able to administer a well-validated quality of life questionnaire, which is URTC QLQC30, to all the patients. In this study, in order to really address and understand more about the quality of life in patients with metastatic gastric cancer, this questionnaire was administered to all the patients with every cycle. So we're able to really assess any change in the quality of life during chemotherapy. We were quite pleased to report that in contrast to some other studies in solid tumors, the response rate, i.e. how many patients actually filled in these quality of life questionnaires, were very, very high. In fact, over 95% of the patients have filled in the baseline, and even with each follow-up visit, the response rate was over 87%, which actually is very high for quality of life questionnaire response from patients. What we, however, observed in this study, is first of all, we, a priori, have decided to look at two endpoints for quality of life. The first one is the time to deterioration of the quality of life. So we define as what is the time from the patient actually have a significant deterioration, which we define as more than 10 points difference compared to baseline, that they've deteriorated but has not subsequently improved. So that would be what we say that there is definitely a time to deterioration. And the second endpoint, quality of life endpoint, is to look at how many patients have improved quality of life, i.e. more than 10 points improvement in the quality of life results, or if it's more than 10 points deterioration, or we call it stable, if they have less than 10 points difference, either improvement or deterioration in the quality of life. So in this study, there was in fact no significant differences between ramucirumab or placebo. Also, i.e. people who have chemotherapy alone or chemotherapy plus ramucirumab in terms of time to deterioration of various quality of life functioning scales and symptom scales, or in fact the proportion of patients who either have an improved or deteriorated quality of life. But actually, the advantage of having no difference between two arms is you can actually look at the whole group, whole 645 patients as a whole, to look at what is the impact of treatment when patients first receive chemotherapy. So these are patients newly diagnosed with the metastatic disease and need to receive first-line chemotherapy. So in fact, it is quite a valuable resource in looking at patient-reported outcome. And what we can see is that at baseline, the most significant symptoms for patients with metastatic gastric cancer is in fact pain, fatigue, and losing the appetite. So that's the most important symptoms. And in terms of functioning scale, the global quality of life as well as the role functioning is the most affected, i.e. the worst when at baseline. And approximately 20% of the patients will see a improvement, in these symptom scales or functioning scales as they start the chemotherapy. And another 30 to 40% of the patient will have their quality of life stabilized with chemotherapy. So we're actually, in quite a large-scale study, able to observe what does treatment mean to patients? What does this treatment actually help the patient? And then it would really help us in clinical practice to talk to patients, because often patients, yes, will ask you, what is my chance of survival? What are my side effects? But in fact, often they will say, actually, what would that do to our quality of life? With all these side effects you just explained to us. So actually, these provide quite a valuable resource for us to explain to patients that as they receive their first chemotherapy and first treatment, this would be the quality of life that they could potentially expect. The limitation of RAINFALL is that it, in fact, has many advantages in terms of it is a placebo control, is well conducted and is a large phase 3, but it is still only conducted in certain countries. For example, because of some consideration of differences in survival between different geographical variations, there is a limit of the number of patients that can be recruited from East Asia, which have the highest proportion of patients with metastatic gastric cancer. So therefore, I think the results of this cannot readily transfer to patients or generalizable to patients from that part of the world. And also the standard chemotherapy used in that part of the world is also different, and therefore I think we have to say that both the efficacy, the side effects and the quality of life data really apply to these chemotherapy drugs in this situation. The next step in terms of developing ramucirumab in second-line setting, this is now regarded as a standard of care. So it would be used as a control arm in future randomized study. And in fact, there is a lot of interest currently looking at different immunotherapy combinations. And some of these studies, although mainly still in randomized phase 2 rather than randomized phase 3 setting, are using paclitaxel ramucirumab as a control arm. And then they would look at different immuno-oncology combination to really have a sense of how they are performing in order to see whether that can be taken up to phase 3. There are also some discussion about combining some other immunotherapy drugs, PD-1, PD-L1 antibodies to this paclitaxel ramucirumab combinations. There are some ongoing prospective single-arm studies, but we will need to see some future randomized study to assess how we take this combination forward in the future.